Yeah, so the prior work, some of it was clinical, some of it was preclinical, suggested there's a clinical activity to combining 5-FU and regorafenib. So I previously published case series on this from my own colorectal cancer clinic. The history of that is when regorafenib was approved and we started putting patients on it, invariably patients would start to progress. And as a GI oncologist, doing this for decades, it wasn't too much of a stretch to say, let's add 5-FU. So that's what I did. I added infusional 5-FU or capecitabine, and there was clearly a signal in every patient who was on regorafenib, to which I added 5-FU. They went from progressive disease to stable disease for various points in time. I tried to do a phase 2 study or a phase 1B, phase 2 study while I was still in Philadelphia at Fox Chase Cancer Center. And I started a clinical trial probably 7 or 8 years ago to do this. The issue at that time was we were not dosing regorafenib well in the clinic. The starting dose was 160 milligrams, and most patients, and this is extremely well known in the field, suffer toxicity, such as fatigue and hand-foot syndrome. And, most clinicians are not really fond of regorafenib. So it was in those days that the dosing was being optimized. And we learned, you start at a lower dose and you can escalate it. And by the time we got around to doing that, the study was accruing poorly, and it was time for me to move to Rhode Island. And so we closed the study, and I still think it's a good study to do at some point, but it's out there. And so TAS102 has some similarity to 5-FU. And so it wasn't too much of a stretch to say, why don't we see how that combination works together? And I would say before I wanted to test regorafenib with 5-FU in the clinic, many years ago, I really wanted to test sorafenib with 5-FU in the clinic. But I think a study was eventually done in Belgium. And, of course, we don't use sorafenib to treat colorectal cancer. And eventually we moved to do regorafenib in the setting of progression on regorafenib. But when we combined TAS102 with regorafenib, there was clear synergy. And then there were some interesting and perhaps unexpected observations that I think we need to study going into the future. And then some other things happened in the field that I'm sure you're aware of that we can discuss. That's a good question. And I will tell you, in the clinic, both Stivarga or regorafenib and TAS102, also known as Lonsurf, were used in the third line setting mostly. That's where they've been approved. And historically, either of them prolonged survival, progression-free survival by a couple of months. Okay, so neither alone as a single agent was particularly exciting. I think most clinicians out there know that Lonsurf is better tolerated. So for some patients, it's preferred, where they would just have a difficult time with Stivarga, especially the way it used to be dosed. So in the last year or so, I think that Lonsurf was approved in combination with bevacizumab, and there the survival was prolonged from 2 months to 6 months, which is huge, hugely important. And it speaks to the type of synergy that one can see by combining Lonsurf with anti-angiogenic agents or anti-VEGF agents. If you look at Regorafenib, it certainly inhibits VEGF receptors and has anti-angiogenic activities. Now, one of the surprising observations we made, especially in the BRAF-driven tumors, we saw evidence of increased vascularity with TAS in the preclinical in vivo studies. And this was overcome by the addition of Regorafenib and the targeting of the pathways that it targets. I think one of the directions that I think may be worth pursuing is that combination in various GI cancers, not just colorectal, but certainly, diseases like gastric cancer would be ripe for testing this sort of combination, mostly because I think it continues to be really challenging to treat those patients. Sort of out there as an approved drug, and it has some similarity to 5-FU in terms of its mechanism. It's clearly an active drug in colorectal cancer that has activity beyond 5-FU. Okay, so it's historically been used in the setting when you've progressed on 5-FU-based therapies and combinations. And so clearly it's not the same, it's different. It's along the same type of mechanism.